mean, I did the minimum document. I mean, I documented what I was supposed to. Yeah, but did you document that you gave him a pillow? Did you because I can't prove that you did it. I was like, can you pull the videotapes? Pull the videotapes in the ER. Prove that I was in there. They're like, no, but you didn't document it. Sounds minor, but I was like, man, that stinks. And of course, because it went all the way up the chain, this was not a just culture at this hospital, hence why I don't work there and haven't worked there for a long time. I got a write-up. The one and only write-up I've ever had in my entire career. Over pillows. And then there's these, remember the nevers, which we'll go over. Okay, could this be you? 5 years ago, you had a patient who died after his condition became worse during your shift. You're pretty sure you remember calling the physician and pretty sure you told the oncoming staff this patient passed away. All of a sudden, you get called into an office. A meeting shows up on your Outlook calendar. That's what happens to me all the time. Now you're being named specifically in a lawsuit against the hospital for the wrongful death. No problem, I documented this. Let me just go back and look. You review the chart. It shows that you called the doctor and passed the information off on during your report. But it's actually not there. You're pretty sure you did it, but it's not there. Do you think you'd be found at fault? Absolutely. Personally. And the hospital can say, oh, you practice on your own. That was outside our policy and procedures. You're on your own. Good luck. Now, I'm not saying we should document or change our behaviors or anything based off of lawsuits, but this is a reality in our life. We have a case right now of a family a patient who developed a bed sore, and they say that it started with us. And they went on to a rehab center, were there, came back multiple times, had to have it debried. The documentation is so poor, the nurses did not know that the patient actually had it prior to arrival. Guess who's writing the check? Not the rehab where he got worse, and he actually went all the way down to a stage 4 and ended up dying from sepsis. We did, because we didn't document it. The wound care nurse was consulted and saw the patient. They ordered a specialty bed. Why would we order a specialty bed on a patient if they didn't have a wound? The wound care nurse also did not document. They just ordered the specialty bed. We now write a big fat check. And then that affects me because then I can't get a raise. It's all about me and how I get more money. So, charting by exception. So again, this is not a shortcut. It requires judgment and expertise. I don't feel like our brand new, unseasoned nurses, as we like to call them, should really be doing this. They need to know what the exception is, and they're still kind of figuring out what the assessment part is, right? Only exceptions are baseline findings are charted. Know your facility's definition of within normal limits or baseline. We do not have a formal definition at UF Health, so I tell my nurses, do not document that, because your normal limits and your baseline are different from mine. I need to know what is that. And just because nothing's written doesn't mean it's normal. You have to remember by charting by exception. Some of our patients, normal, for like normal skin, might be different for you and for me, right? So that's why it needs to be documented. Okay. One of the things about defensive charting is you need to just ask yourself, am I creating a clear picture? That's the whole thing. You want to tell the story. You want to tell it from top to bottom, okay? Am I charting to alert a provider about the patient's changes or findings? If the next coming shift or during rounds, they look at these vital signs or they look at what's happening, can they tell that this patient is circling the drain? Right? Is my charting mechanical almost? Rapid clicking and scrolling. And then I go back and I'm like, why did you document that? Sorry. Yeah. I was just clicking. I had something else to do. I got 3 phone calls in the middle of it. I had a patient, screaming. I had another one I had to take to CT emergently. So I was just clicking and scrolling through. I wasn't actually actively involved in documenting. And yes, I say document everything. I had another case where I was at shock trauma. I had a patient who came in the middle of the night when I worked night shift, who EMS told me, oh, this is Mr. So-and-so. We pick him up all the time, and we usually take him to the ED because he's a heroin addict. He's found laying on the ground. He says he can't move. Because he was found on the ground and says he can't move, we have to bring him to trauma because we think he fell off this fence or whatever. But he's probably just high. Give him some time to sober up and you can probably get him out of here. All right, whatever. So he comes in. He's a little cooperative. With some Narcan, he's a little more awake. We scan him. But I noticed that his neurological assessment is really odd. He really cannot move his feet. He cannot feel me. And his arms are like floppy like this. He's doing the chicken wing. And I'm like, I don't like those. So we scan him. Everything comes back normal except for his neck looks like there's some degenerative findings. Like it looks like his neck's kind of, messed up. It's like he's older. So the resident comes in and says, she was a visiting resident during her rotation, and comes in and she says to me, we can take his collar off and clear him. He can go home. I said, I'm telling you, there's something not right about this guy. She's like, no, just take his collar off. Well, I refuse to take his collar off. So she comes over and sits him up and takes his collar off. And what's he do? Slumps to the side. Right? We go back and forth. Finally, I'm like, okay, I've had it with you. I'm going higher. Right? Go follow my chain of command. So I talk to my fellow. My fellow's like, let me talk to the attending. The attending's in the OR. He's had a terrible night. He's like, look, I looked at the scan. It says fine. She's telling me his exam's good. Just get him out of here. I'm like, I'm not calling his family. By the way, it's like 3 in the morning. So I'm like, you know what? Let's just let him sleep it off. We weren't slammed. We weren't busy. I said, it's okay. He was cooperative. Of course, I laid him back down. And I put his collar back on. She calls his brother, who shows up at 3:34 in the morning. She says he's being discharged. And she's like, come on, get up. And he's like, I can't move. I got this burning sensation everywhere. And I'm like, I'm telling you another time, something's not right about this guy. I'm telling you, and I'm documenting this as we go along, and I'm documenting, spoke to charge nurse, spoke to, so-and-so and so-and-so, and I'm not calling anyone out like I wanted to say she's an idiot, but I didn't. I kept that to myself, and so anyways, I document all this stuff. And very early, it was about 6 in the morning, the attending who was on, we barely saw him, he was in the OR all night with some ICU patients. So he runs in, gives a quick blowdown of what's left here, leaves, trusting that his fellow and that his residents have done good exams and everything. And the oncoming attending comes in, and I pull the oncoming nurse aside and I said, look, this don't look good. Chart. And it turned out he was emergently rushed to the OR and he's a paraplegic. I don't think we would have changed the outcome, but 2 weeks later, when I get called into a big boardroom with all these people, and they're like, can you explain your documentation? I'm like, well, it's right there, what I found. Well, why is yours so different than hers? I said, I can't explain her documentation. I'm not her. I wanted to say because she's an idiot, but I didn't. You don't do that. You can't call colleagues like that. So I just said, I can't explain it. Here's my documentation. Right? And it covered me. It saved me. It was what I really saw. I documented what I really saw. Now, I'm not saying that I don't think it would have changed his outcome. I think he was a para as soon as he rolled in. But we quickly made judgments. He's a heroin addict. He's always here. And it saved me, though. Because I really think that the hospital would have been like, whoop, that's on you. What happened physician-wise, I have no idea. She was a visiting resident. She finished her, and she moved on. So can you convince a judge or a jury with what you're documenting? A layperson. Anyone had to testify? It's good times, huh? Yeah, that's how I want to spend my day off. Yeah. I've had to testify for blood alcohol. Thank you, Anne Arundel County of Maryland. They call you in. They'll put a bench warrant out for you if you don't show up. Do you know how intimidating it is to sit there and try to tell a judge and prosecutor and a defense attorney, and they're trying to prove that you don't know what you're doing, and I'm like, I know how to draw blood. I mean, hello, I work in shock trauma. If I don't know how to draw blood, maybe I need a new job, right? But I have to prove that to them. It's not fun. And then I had to pay for my own parking at the courthouse, which really made me upset. $4 and I can't get reimbursed at work, and I only got paid for 2 hours of being the 6 hours I was there. Just saying, I have a little negative outcome on that, right? Little upset about that, not bitter at all. Anyways, it's not fun times. You got better things you'd rather do with your time. The biggest thing I can tell you is know your facility's policies and procedures. They were put there for patient protection and for you. I can't tell you how many nurses I say to them, our stroke patients, for example, what is our policy and procedure post-TPA vital signs? Well, my preceptor told me. I don't care what your preceptor told you. What is our policy? Know how to find them. Follow them. If they're not right, yes, it takes an act of Congress and God to help you change a policy and procedure. But if it's not correct, it's not what you're following, it's not your actual practice, then you need to help create that, right? You need to change that to what you really do practice based off of best practice. Okay, here's some nevers. Frequent flyer. ETOH on board. You could say, I have the smell of ETOH coming from their mouth, or whatever came out of that NG tube is definitely tequila, right? But you don't write that. You have to write large smell, brown liquid with smell of ETOH to it, right? Or maybe not even say that, just describe the liquid. They're acting crazy. What does that mean? They're doing well. What's well? Well for them, well for you. If they're that well, why are they here? No change, that's my favorite one. No change from what? From the previous shift, from the day before, from the last assessment, from the what? What does that mean? I've written that, no change. It doesn't mean anything though, right? Love this. Okay. As much as I want to sometimes write this, we all have those colleagues that we struggle working with, right? We'll all admit it. The patient's chart is not your personal diary. Don't talk about how Nurse Betty left the room a hot mess and I had to spend half the day cleaning it up. Right? Doctor refused to see the patient and then was rude to us. That is not the time or place to discuss it. I love this one. Due to nursing short staff, which I've seen this, patient did not get medication. Don't put that. That's not an excuse. That's not good. Right? We still got to function. That's something you need to take up with your manager, and there's other ways to handle this. This is not your personal diary. In another patient's room doing dressing change, so I missed it. Oh, I missed the plan and rounds due to being off the floor with another patient. Don't say that. It's still your responsibility to figure it out. These are real things that we've seen. Okay? Charting before it's done. Anyone done that? I did that earlier in my career. I pulled out a medication, charted that I gave it, went in there, and then the patient refused it, and I was like, oh, son. Right? Then I had to go waste it, and then I'd go back and fix my charting, and then that took me an extra 10 minutes. Oh, but I got distracted 5 times on the way. Right? Charting something you didn't understand. Well, I'm just documenting these ICP numbers. Are you supposed to do something about them? You mean 50 is not okay? Oh, maybe I should have done something about it. If you don't understand, find your resource person. Ask that person, right? Ask somebody, how do I document this? I had a patient who had a lot of different wounds and things, and he ended up having some of the rash and stuff came from the chest tube dressing change that he had, and it had ripped some skin, and the nurse was like, how do I write this? I said, this is what you're going to write. See what you see? That's what we're going to write, right? Changing or adding documentation. We can do that. You have to know your state and your policy for your hospital. But what you need to do is put the current date that you went back and changed that. Now, with EMRs, it's time-stamped, so don't think that you're going to go back and document it and that no one will know that it wasn't done. I had a nurse who missed a restraint documentation, and at our hospital, you get called back in. Okay? We check it every 12 hours. And if you've missed documentation, I don't care if you just got off a shift and drove an hour home, you're driving back to the hospital to fix it. I don't care if you're back that night, you're fixing it then. So, needless to say, we don't miss a lot of restraint documentation. But they come back, they fill it in for the 2 o'clock or whatever time frame, right? Well, guess what? That's time-stamped of when you actually did it. So it's not like, oh, I actually did do it and now it's on there, right? So, oh, it was actually done. No, you need to actually timestamp it. If you go back and make a note, you need to timestamp when you actually did it. Okay, it's okay that you forgot something. I do that. I'm halfway home and I'm like, oh, I forgot to put in whatever. I forgot to document whatever, or I forgot this part. It was so crazy, everything that happened, trying to get my thoughts together to get it in there. You know, I needed that time to go back and think. If you know it's in litigation or review, don't touch it. Okay? Because they'll use that against you. Ooh. Okay, so I have this great video, but I don't think it's going to work. I don't know, but Gerald, will this work if I use the internet? You guys know Z-Dog? Love him. Love him. Let me see if I can get it this way. I should have pulled it up earlier. Sorry, guys. Because I don't think it'll work in my presentation. But I think it just kind of sums everything up. Oh, maybe we don't have internet. We don't have internet, I'm sorry guys. You have to Google this on YouTube. Z-Dog EHRs. Great. It's fabulous. Sorry, I forgot about this, or else I would have set it up earlier. Anyone have any questions?